Okay, hopping over to the Word document here. So I want to talk through differential diagnosis at the elbow today, orthopedic differential diagnosis at the elbow. Consistent with the other areas that we've talked about in differential diagnosis, I just wanted to present the basic schema for differential diagnosis of pain patterns, so musculoskeletal pain versus neuromuscular pain versus non-MSK or cancer-related pain. So I'm going to leave the definitions there for your reference, but I'm not going to talk through those because I really want to get to elbow. There's a lot to go through as far as diagnoses here. At the elbow, the main categories of diagnosis and injury that we're thinking about at the elbow, or that I tend to think about or tend to group within, are a tendinopathy presentation where the muscle tendon unit or the contractile unit has been irritated. Common subjective findings or mechanism of injury onset that is typically reported are repetitive overuse or repetitive motion type injuries. So repetitive gripping, repetitive typing, mousing, upper extremity use will commonly be described as contributing to these tendinopathies of the upper extremity. Some objective findings that are common within upper extremity tendinopathies and lower extremity, but we're talking about upper extremity here around the elbow, is that the pain is usually localized. As we're thinking about the elbow, it's usually localized to the common flexor tendon insertion, medial epicondyle, or common extensor tendon insertion, lateral epicondyle. The tendon or the symptom presentation tends to be described as one that warms up. In other words, it's worse at the beginning of activity, but as an individual gets into activity, it may actually go away. So the start of a tennis match, somebody might describe a lot of pain at the elbow, but it might go away during the match, and it might return after the match. It might be achy or dull, like a delayed onset. But the pain typically gets better with movement, better with activity. That's characteristic of this type of issue. And then there's pain with active contraction and passive stretch. So that's the pattern that we see with these contractile lesions. First, well, I'm not sure first, but I believe it is first described by James Syriac, so father of orthopedic medicine, describes this pain pattern of contractile lesions. In other words, if it's a muscle or tendon issue, you have pain when that contractile tissue, the muscle and tendon, contracts or shortens, pain with that active shortening, and then also pain with passive stretch. So if we think about this pattern as part of our objective exam, if we suspect this sort of issue, contractile lesion, an issue of the tendon or muscle, but we're talking about tendinopathy here, we're going to be able to recreate that individual's pain if we ask them to contract the muscle that attaches the tendon, or if we place that tendon on stretch. That's going to be a common finding. The other thing that we see at the elbow commonly, because of where these different, so three major nerves to the more distal upper extremity are going to be median nerve, ulnar nerve, and radial nerve. What we'll see, because they move around the elbow or they pass across the elbow, sometimes we'll see nerve entrapments at the elbow. The mechanism and onset is not necessarily within a specific pattern, and it doesn't tend to be traumatic or acute, but it also doesn't tend to follow a really specific pattern of injury. So that might be a little bit hard to localize. However, some of our objective findings can give us clues to whether this is a neural tissue issue or nerve entrapment issue. And some of these tests are going to be the characteristic upper limb tension tests for those median, ulnar, and radial nerves. We can also see a positive Tinel's test in many cases where we're tapping the nerve at a superficial place, and that tapping or that force applied to the nerve will reproduce symptoms, or compression at that nerve will reproduce symptoms. And then people are going to describe symptoms of neural tissue origin, such as paresthesias, numbness, tingling, weakness, shooting or burning pain are more characteristic of a nerve issue versus a musculoskeletal issue. Ligament issues, these tend to be due to a high velocity or forceful impact that stresses the ligament, tears the ligament. or a loading moment, or, and I'm gonna differentiate a little bit from what I typed here, so repetitive overuse, so repetitive forces can also contribute to ligament issue, especially we'll see that at the medial elbow, the ulnar collateral ligament can be due to a high force, but cumulative high force over time. So the repetitive throwing is what I'm referring to when I talk about the UCL injury or a Tommy John injury, as it's also called. And then our testing for ligaments at the elbow, we're typically going to test via a varus or a valgus stress test. And these can be applied at 0 degrees of elbow flexion and also 30 degrees of elbow flexion. Remembering that our tests at 0 degrees of flexion are going to stress not only the ligaments, but also the capsule of the elbow. And if somebody has deficits at 0 degrees or positive tests at 0 degrees, that's going to be indicative of a more severe injury. As we test at 30 degrees of elbow flexion, that's going to place more stress, more localized stress on the ligaments at the elbow instead of the capsule. So that's something to keep in mind, is the different variations of the stress tests. That's how we're going to test for ligament. Bone fracture dislocation tend to be these high velocity mechanism of injury, a fall, an impact trauma, those sorts of things. And you're going to have tenderness at the bone. You may have an observed incongruity in the case of a dislocation. Posterior elbow dislocation is the most common direction for humeral-ulnar dislocation. You're going to have positive x-ray findings. So you're going to show evidence of fracture in most cases and or dislocation. The other thing I wanted to note is to remember that since we're in the upper extremity, there could be potential referral pain to the elbow from the cervical spine. So instead of a tissue at the elbow being the cause of symptoms, we could have symptoms that are generated from the neck that refer down to the elbow. So your differentiating factors here are going to be your provocation test at the neck. So if you can create forces at the neck that reproduce a patient's elbow pain, then we're thinking maybe the neck is the pain generator versus tissues around the elbow. So those are going to be your joint tests, cervical CPAs and UPAs, cervical muscle palpation. It's going to be important to rule out the neck, and then also your neurodynamic testing. All right, so moving into these specific diagnoses, the first two are going to be in that category of tendinopathy, so lateral epicondylalgia. Commonly described, or the colloquial term for this would be tennis elbow. And this is going to be, again, that repetitive overuse injury. Pain is going to be localized to the lateral epicondyle usually. Your objective testing you're going to perform is going to be consistent with that Cyriak's diagnostic pattern. So you're going to passively stretch the tissue, and you're going to actively ask them to contract and apply resistance. And those two tests are special tests for this area. So Mills test is going to be your stretch. Your Cosen's test is going to be your MMT on the muscles that pull on that tendon. So those are going to be your wrist extensors. ECRBNL primarily, although we know centra digitorum could also contribute to lateral epicondylalgia, and that's its own separate test called Maudsley's test. So the eponym is Maudsley's test, but then it's also been described as the resisted third digit extension test, which is kind of a mouthful, but you get the idea. This individual, if it's purely an epicondylalgia, if it's purely pain at that epicondyle or tendinopathy pain, they're not going to have a positive radial nerve test. So it's not going to be a nervous issue, nervous tissue issue. It's going to be more of a tendon issue. However, you could have a patient who has both of these things going on. So just keep that in mind. But for a pure diagnosis, just a single simple diagnosis of epicondylalgia, you're not going to have a positive radial nerve provocation test. They're going to be tender at that lateral epicondyle. They could have reduced grip strength because we know those wrist extensors contribute to a forceful grip to counteract force from the finger flexors. In medial epicondylalgia, it's going to be a similar presentation, but on the opposite side of the elbow. So we're thinking medial epicondyle is going to be the common insertion for the wrist flexors and pronators. So they're going to have a painful wrist flexion. They're going to have painful pronation. So pain with pronation is a common finding as well. And okay. So pain with pronation, common finding as well because of the insertion of those pronators on the medial epicondyle. You're gonna have tenderness in the medial epicondyle, again, reduced grip strength, painful grip, going to be common to that diagnosis. Little Leaguer's elbow is a diagnosis that's going to be akin to these epicondylolgias in an adult, but it's a pediatric diagnosis. So I promise I will add this updated document. I make a few notes. I don't get it all in there when I first my first go round. So I'll add this updated one for your reference in the comments. But Little Leaguer's elbow is going to be typically pain at that medial epicondyle, but pain at the apophysis or at the insertion of the tendon into the bone at the growth plate. So that apophysis or that attachment tends to get irritated versus the tendon site. And what we also know in pediatrics is that they are more prone to these avulsion fractures. In adults, we tend to see tendon injuries. In pediatrics, just because of the state of the bone formation and remodeling, they will tend to be more prone to a bone injury, specifically an avulsion fracture at that area. So that's something that we want to rule out, especially if this individual is not responding to conservative care. Might necessitate imaging to rule out an avulsion. This is true in the upper extremity, but it's also true in the lower extremity, where sometimes I've worked with patients who have had hip flexor strain, and the hip flexor strain that's not responding may be due to partial avulsion fracture at the AIIS or ASIS, thinking about the muscles that attach to those different areas, so rectus femoris, AIIS, and ASIS, your TFL, both hip flexors. Again, that's a little bit of a tangent, but I think it's important to rule out in your pediatric patient. Okay, we can also see tendinopathy of the distal biceps tendon. This can be due to, again, repetitive overuse. Pain will be localized to that distal biceps, either the tendon, could be in the muscle belly as well, some tenderness and pain or just dysfunction. So you could see some weakness, and objectively, we're going to see a painful elbow flexion MMT or muscle testing, but also because of the biceps contribution as a strong supinator, likely supination is going to be painful for them. And they could be, again, tender at that distal biceps. I didn't put these two tests on here, but I just wanted to mention them. These individuals could have provocative or painful Speed's test and Yergeson's test. However, those are more, as they're described, tests for a proximal biceps issue, not that it's not all attached, but that's the reason I left those off. Your biceps tendinopathy that's distal, I think some of the keys there are going to be more your palpation and then your test around the elbow. Not to say that you aren't going to provoke pain with the other bicep test. And then a biceps tendon rupture, so a full rupture of that distal biceps tendon, is going to be described usually with a quick eccentric load, so quick traumatic loading of that biceps, either catching something that's heavy or lifting something that's really heavy. It doesn't have to be eccentric, it can be concentric. Usually eccentric is the mechanism, but it could be concentric. So heavy lifting, commonly described in middle-aged males who are moving furniture. It's pretty common MOI. And this person's going to have weak elbow flexion because of the contribution of the biceps to flexion at the elbow. It could be painful, although one thing that we see described is that a full rupture of a muscle or tendon sometimes is painless. So that's something to keep in mind because that tissue has been fully torn. The other things that we see with this full biceps tendon rupture, sorry, I didn't mean to scroll, are positive hooks test, where you're literally trying to use your finger and hook the tendon of that distal biceps. If you can't hook the tendon, and it's probably fully torn, not there. In fact, that test is 100% sensitive and specific. So if that test is positive, you are very sure that it's a biceps tendon rupture. If it's negative, if you can hook some tendon with your finger, if you can kind of palpate and hook it with your finger, then you're pretty sure it's not a full tear. There's some tendon that's left. So that's a really good one. Keep that in mind. The other tests that you might perform if you forget about the Hooks test or if you just want to be totally sure are you could note a Popeye deformity where that tendon kind of balls up, the muscle belly balls up, and you get this little bulge in the muscle belly because of that retracted tendon. Squeeze test, which is very similar to the test for Achilles rupture, where you squeeze the muscle belly of either calf, or in this case, you squeeze the muscle belly of the biceps. And if you see an action at the tendon, so in this case, it would be elbow flexion, then you can be confident that there is some intact tendon because of that action that you see. By squeezing the muscle belly, it's a little bit of a reflexive myotactic reflex test, but in an indirect way. So it's a special test that we describe. These individuals, it's really important to note that we want to get them to a surgeon quickly if it's a full tear. We want that tendon to be reattached within 10 days for the best outcomes. Usually this individual is going to have surgery. It's a no-brainer. For a lower level or older patient, it is an elective surgery, so they might defer surgery. The only issue with not having surgery is you could have a little bit of weakness. However, you do have other elbow flexors that can compensate. But the most significant issue that these individuals face who defer surgery is actually just the cosmesis of it. So just having that Popeye deformity or deficit, if they don't care and their function is not affected, they might defer surgery. All right. Cervical radiculopathy, I have the test cluster in here for your reference. So these are the 4 tests that are commonly described to rule in cervical radiculopathy. It's a Wayner test cluster. So if 3 out of 4 or 4 out of 4 are positive, you have upwards of 90% chance that it is a radiculopathy. So if you do have upper extremity symptoms, even at the elbow, and you suspect radiculopathy, I would encourage you to go through this test cluster. And if you only have 1 or 2, then maybe you can be less confident in radiculopathy. But if you have a lot, 3 or 4 positive test findings, then maybe you're reproducing elbow pain, then maybe you have some radiculopathy. So that's a good thing to keep in mind. These nerve issues at the elbow, let me make sure we get to everything here. Yep, we'll be okay. So these nerve issues at the elbow, 3 main nerves we're thinking about are median nerve. So median nerve at the elbow is going to run through that antecubital fossa, so the elbow pit, if you will. And median nerve issue is going to result in deficits in the areas of the median nerve supplies. So the muscles that the median nerve supplies are going to be flexors at the wrist, but also some of the hand intrinsics, pronators, are going to be median nerve. In the hand, the median nerve is going to supply fewer muscles and the ulnar nerve is going to supply more. So I tend to think of median nerve as greedy at the elbow and wrist. Ulnar nerve is greedy at the hand or with hand intrinsics. That's just a little trick I use to try to remember that the median nerve is going to supply more muscles to the elbow and wrist. The ulnar nerve is going to supply more muscles that are hand intrinsics, and that breakdown between the two is sometimes confusing based on which each supply, but that's something that I feel like helps me simplify it. Another thing to note is that there is a branch of the median nerve that is sometimes tested for differentially, and that is this anterior interosseous nerve, which is purely a motor branch of the median nerve, so there's no sensory innervation from that anterior interosseous nerve. So if you have sensory deficits, it is not anterior interosseous syndrome. It could be a median nerve entrapment, but it's not specific to this branch because this branch does not have any sensory contributions. This branch is going to supply more of the distal muscles and kind of, I think of just the finger muscles. So flexor pollicis longus and flexor digitorum profundus, 2 digits 2 and 3 are going to be from this anterior interosseous nerve, some motor functions. And then the pronator quadratus, which if you remember is more towards the distal radial ulnar joint and contributes to pronation there. Pronator teres is localized more proximal, and that's going to be from that main median nerve branch versus anterior interosseous. Some positive tests for median nerve pathology: you're going to utilize your upper limb tension test of the median nerve. You're going to utilize a resisted pronation to try to differentiate Pronator syndrome. So if that median nerve is getting compressed via its course through the two heads of the pronator, then getting that pronator to contract via resisted pronation should be provocative. In other words, that should be a way to reproduce symptoms if that is in fact what is going on. You could have tenderness or provocation of symptoms if you're able to palpate the median nerve at the elbow. The reason I put on here not carpal tunnels is we're talking about median nerve entrapments at the elbow. So your carpal tunnel tests are not necessarily going to be positive. In fact, if you're arguing that this is a median nerve issue at the elbow, those carpal tunnel tests are going to be negative. So your phalanx test or your wrist flexion test, your carpal compression, where you're placing compression forces on the median nerve at the wrist joint, your prayer test, which is a reverse phalanx, Tunnels of the carpal tunnel, your OK test, which is, this is actually testing integrity of the flexor pollicis longus and FDP. So this OK test, I'm just going to put in parentheses, is a test for the more specifically anterior interosseous nerve. And that is your ability to make that OK sign. If you lose that inability, what you're going to see is you're going to see an adduction or more of a pinch of the thumb and first finger instead of a round OK. And what that is that's going to be an ulnar nerve substitution with the adductor pollicis instead of the flexor pollicis longus. Instead of flexion at that DIP, you're going to utilize adduction to substitute. So that OK test is one way to test that specific branch. And again, like we said, if it's truly median nerve at the elbow and not at the wrist, your thenar function, your intrinsics should be intact as long as you're not losing. Again, there's a little bit of a caveat here. As long as you're not losing everything downstream, your provocation tests at the wrist should be negative. I guess theoretically you could lose all hand intrinsics, in which case you could trace the deficit upstream more to the proximal median nerve. So keep that in mind, but I think that hopefully that makes sense what I'm trying to differentiate there. Ulnar nerve, if it's an ulnar nerve injury, we're going to see a positive ulnar nerve upper limb tension test. Froment's sign, which is the ability to utilize that adductor pollicis function. If you lose that, that can be indicative of ulnar nerve pathology. Usually with these ulnar nerve entrapments at the elbow, we're going to see positive elbow flexion tests. So any sort of elbow flexion is going to provoke. And we can remember the course of the ulnar nerve passes through that cubital tunnel. As you flex the elbow, you're going to stretch the ulnar nerve in that cubital tunnel. So that's really the provocation for that. If we think about the communication that the ulnar nerve contributes to, both motor and sensory. Motor, we're going to lose a little bit of function at the wrist. So flexor carpi ulnaris, so flexion plus ulnar deviation might be a test that you utilize to check out ulnar nerve pathology. Sensory loss, we can also localize within a specific pattern. So paresthesias within the fifth digit, and I put fourth on here, but really we're thinking half of the fourth digit is going to be the ulnar nerve territory. So those are going to be characteristic of ulnar nerve lesions. Also positive Tunnels at the cubital tunnel because of how superficial that ulnar nerve is at the cubital tunnel. This is a really nice test to provoke and try to reproduce patient's symptoms. So it's pretty easy to tap on the ulnar nerve via the cubital tunnel, and people often describe this as, oh, I hit my funny bone, I have numbness and tingling. That's usually because they hit their ulnar nerve at that superficial spot at the cubital tunnel. Radial nerve injury is going to be characterized by loss of wrist extension function. It could be weak elbow extension as well. And this clinically will manifest as a wrist drop if it's very severe. This wrist drop, wrist drop will be characteristic position of a flopping of the wrist into flexion because there's no ability to actively extend the wrist in a very severe radial nerve palsy or radial nerve lesion. The other thing that we see, and this is kind of analogous to the median nerve, is what's called supinator syndrome. So as the radial nerve passes through heads of the supinator, it can become compressed. So you can have not only weak and painful elbow and wrist extensors, so I'm going to put that in there, but you could have weak and painful active supination as the supinator muscle compresses the radial nerve. So that's one thing that you might see, and the supinator muscle is supplied by the radial nerve, so that's another contribution to that. Another analogy or another analogous nerve branch in the radial nerve is the posterior interosseous nerve, which functions very similarly to the anterior interosseous and the median nerve. The posterior interosseous nerve is a distal branch of the radial nerve, and it supplies these outcropping muscles or snuff box muscles. So the extensor pollicis longus, extensor pollicis brevis, abductor pollicis longus are all supplied by that distal branch. Again, posterior interosseous nerve has no sensory innervation, so if you see motor deficits of these thumb muscles but no sensory loss, you can think maybe this is the culprit versus the main branch of the radial nerve. Radial nerve sensory territory, and I promise I'll update this, but sensory loss of the dorsum of the thumb is characteristic of radial nerve pathology. So the radial nerve has less sensory territory than ulnar and median, but it still does have some sensory branches distally, and that's where they go, is dorsum of the thumb. Last few pathologies that I'm hoping to get to before we run out of time are these pathologies due to trauma. So UCL injury, as mentioned above, is going to be more of a either high velocity valgus stress at the elbow or repetitive overuse, sometimes called Tommy John's injury due to this famous baseball player who had this injury, and the treatment for it is also called Tommy John's surgery. So those are common terms. To fully diagnose this issue medically, you utilize an MRI because it is a soft tissue lesion. And just to remember within throwing, because throwing is such a common mechanism for this injury, is that this valgus force is going to be very high at the late cocking phase of throwing, but then also deceleration phase, where you're decelerating with your shoulder external rotators, and that's why I have this in here. But what we're really thinking about is these are the points in time during the throwing phase where your valgus force at the elbow is significant. So if you're going through repetitive throwing, you're getting valgus force, valgus force, valgus force, valgus force at each of these places for every throw that you undertake. These are your clinical tests right here on the right for a UCL injury, so pain provocation, but also you can reproduce laxity for a severe tear or deficit. So the valgus stress test, milking maneuver, positive MRI, again, showing tear. Tenderness at the medial epicondyle because of where the UCL inserts, specifically the anterior band, is a pretty common finding. Moving valgus stress test is another one. Pediatric diagnosis that I threw in here was Nursemaids Elbow. And this is where the radial head is subluxed from the annular ligament. It's commonly described where a child is pulled up by their arm and you have this strong force that subluxes that radial head. Usually it's in younger pediatrics, so 1 to 5 is the age range that I have heard it commonly described in. An electroline fracture, similar to most fractures, you're going to utilize X-ray to diagnose. It's going to be trauma that contributes to this specific injury. Not a common place for stress fracture, so it's usually due to trauma. You're going to have tenderness at the bone. The other thing I will put in here that I failed to add is loss. So clinically one of the tests that we utilize to diagnose, maybe not diagnose, but at least suspect fracture at the elbow is loss of active range of motion, and this could be in flexion or extension. So somebody who comes in with a mechanism of trauma and they do not have full active range of motion, either in flexion or extension, usually we're sending that patient out for x-rays. Posterior dislocation at the elbow, common mechanism is going to be trauma. Usually there's a visual deformity where that ulna has been displaced posterior. And I'll type that in there. And you will see that usually visually, but also on your imaging findings, X-ray or MRI. For that posterior dislocation, you can usually see it on X-ray, but it could be MRI as well, just to see what the extent of soft tissue injury is, or if there's ligamentous damage as well. For these individuals, they're going to have some post-surgical limits in range of motion or post-surgical weakness, or just post-injury weakness and limitations that you're likely going to treat in physical therapy, whether they are casted or immobilized to treat and try to allow for healing. Could be a dislocation plus fracture, so that might be some instance where you're seeing a patient after they've been casted and treating them after cast. So not that we see a ton of these, but you could see them after the fact, after they've been immobilized, and then you're treating them in physical therapy. I am not aware. I feel like this is a diagnosis that they know there's been a trauma. They're not going to seek physical therapy as first line of care, but you will see these patients down the road a little bit for dislocation. So that'll be important to kind of think through what some of their deficits might be and how you're going to help treat their limitations in motion and strength. Last couple here, proximal radial fracture or radial head fracture. So again, we're thinking about elbow differentials. We know a common fracture of the radius is a Colles fracture, which is a distal radius fracture. And however, a proximal radius fracture could occur. If you have trauma at the elbow, it could result in a radial fracture, could result in a olecranon fracture like we saw above, but it could be a radial fracture. Usually due to trauma. In older age, usually we will see a Colles fracture with a fallen outstretched hand or a foot injury. Pediatrics actually we will see more of a radial head fracture versus a distal radius fracture. And again, that has to do with just how the force is dissipated through more immature bone versus a stiffer bone in an older age will fracture more distally. So that might be something to think about, the likelihood based on age. And then diagnosis for these fracture, the medical diagnosis is going to be via imaging, via X-ray. Olecranon bursitis, or inflammation of that bursa overlying the olecranon or point of the elbow, is usually going to due to trauma and just bumping your elbow, and that bursa gets inflamed. Usually there will be a visual indication of this, and the bursa will become puffy or inflamed, and you'll be able to see this. Main testing for this is going to be notable. They're going to be painful to palpation at that bursa, and you're going to want to rule out other causes or sources of pain, but usually this is more of an obvious diagnosis because it's observable, and that bursa is so superficial. So I'm just going to put tenderness at the bursa, but that's pretty obvious. You could note some bogginess and swelling as well at that inflamed bursa. And then these are some treatment ideas. So one thing that I have on my blog site is this series of treatments for tendinopathy. This series is specific to lower extremity tendinopathy. However, the goal with upper extremity tendinopathy is very similar to these lower extremity tendinopathies, in which case we're trying to build load tolerance of that tendon, and we're trying to progress load based on a very specific paradigm in which we apply low loads at slow speed and then higher loads at slow speed. And finally, the last stage of rehab is that we're applying high loads at fast speed. And we know, or we extrapolate based on the research, that that's the best way to rehab these tendinopathies. And I think it holds true for upper extremity in addition to lower extremity. So if you're interested in more of a treatment paradigm or stepping patients through treatments in an intelligent way, I would encourage you to check out those blogs just because there's more information there than what I'm able to get to in talking through it today. When we're thinking about applying load to these specific tendinopathies, we want to target the muscle group and tendon of interest to try to build load tolerance. So again, when we're thinking about the lateral epicondyle, we want to target those wrist extensor group and supinators, medial epicondyle, wrist flexors and pronators. Biceps, we want to really train elbow flexion as well as supination. We could train shoulder flexion as well, again, because biceps is continuous, so pull in both places are going to contribute. We want to train grip strength for all of these individuals. And then eventually we want to train mobility if it's indicated. I wouldn't recommend stretching in the short term if it's irritating, because you're just going to cause flare-ups or irritation on those individuals. A couple other thoughts on treatment, just some treatment ideas for loss of elbow motion. If you're losing supination, pronation, as I mentioned above, the main contributor in terms of joints are going to be our proximal and distal radial ulnar joints. And remembering the arthrokinematics of those joints are different because of the joint surfaces. So if you're treating with joint mobilizations, just remember your arthrokinematics of those joints to help guide your choice of treatment. So for example, if you're wanting to improve supination, forearm supination, and you're treating at the proximal radial ulnar joint, you can remember that the radial head is going to move on the radial notch in the ulna. So the radius is moving on the ulna, the radial head is moving. And if I supinate, if I turn my hand up, then that radial head is going to roll posterior, and it's going to glide opposite because the convex shape of that radial head. So it's going to roll posterior and glide anterior. You can reverse those kinematics for the distal radial ulnar joint, because the distal joint, you're going to have the radius sliding, the concave distal radius sliding on the ulna. And so you're going to have a roll and glide in the same direction. So you can piece through that, but I just wanted to remind you of those kinematics as you're thinking through treatment options for supination and pronation if you're thinking it's joint related. Of course, it might be a muscle restriction, in which case your interventions might be that you select might be more of stretching or muscle treatment interventions. Elbow loss of motion for flexion or extension. Again, it could be that it's a joint issue or it could be a muscle issue. So you're going to treat based on what you suspect, what tissue you suspect is involved. You might treat both and see what helps. But there's some ideas again for you there. Some joint mobilizations they may utilize are distraction to treat the capsule and try to encourage both flexion and extension. Some stretching of muscles, either short intense or long hold. And then your strength around the elbow, you're going to want to train flexion, extension, pronation, and supination of the forearm. You could train other upper extremity kinetic chain deficits as you note them. So deficits of the wrist, deficits of the shoulder are going to be important if you find those deficits. Okay. Thank you for joining for a little bit of discussion of the elbow. I'm going to come back here.